Mm. Okay, so I'm live. So, hi everyone. Hello, my dear students. How are you doing? So, I know probably your first term is around and you must be studying hard for that. So, today, we'll have some points or the questions that can be asked, in exams, which are concept based. Like, first of all, guys, let's talk about something that is called as glycogen storage disease, and that is especially type 1. Okay, so in type 1, guys, a lot of questions can be made, especially, it presents with a lot of symptoms. Okay, a lot of features there are in the type 1 glycogen storage disease that is also called as von Gerke's disease. So, guys, what is von Gerke's disease? It is caused by deficiency of glucose 6 phosphatase enzyme, right? This is an enzyme which is unique enzyme. You know why? There are a lot of things that you should know about glucose 6 phosphatase. First thing that you should know is that it is a marker enzyme of endoplasmic reticulum. You know what are marker enzymes? Marker enzymes are the enzymes which are specifically found in particular, cell organelle. That's called as marker enzyme. So first thing again, it's a marker enzyme of endoplasmic reticulum. Second thing, it is the last and final step of two pathways, gluconeogenesis and glycogenolysis. Again, repeating, last and final step, okay, of gluconeogenesis and glycogenolysis. So, guys, gluconeogenesis and glycogenolysis are the only two mechanisms in our body which maintains our fasting blood glucose levels. You know, now fasting blood glucose levels are very important to keep our brain working, to keep our brain healthy, right? Okay, energetic. So this enzyme is the enzyme which is common to both these pathways which maintain our blood sugar levels. Okay, and the third thing that we are already discussing is that glucose 6 phosphatase, if it is deficient, it causes von Gerke's disease. So now can you tell me what will be the most common symptom of the von Gerke's disease? So in the exam, if I ask you that why there is hypoglycemia in the von Gerke's disease. So how will you explain that? So guys, now we have already explained it. So how to explain this? The most common symptom is hypoglycemia, fasting hypoglycemia. So why there is fasting hypoglycemia, guys? Can you explain this? So because in the von Gerke's disease, glucose 6 phosphatase enzyme is missing or deficient, and because of its deficiency, the two pathways which maintain our only two pathways which maintain our blood sugar, that is gluconeogenesis and glycogenolysis, they will be decreased, right, substantially. So when they are decreased, then the blood sugar cannot be maintained. So that is the biggest problem of the patient of von Gerke's disease. And that is why, guys, the only treatment that you can think of for the treatment of von Gerke's disease is giving the baby food which is full of carbohydrates every 2 to 3 hours. Fine. So initial 6 months the mother is given breastfeeding, but after 6 months, again you have to feed the baby every 2 to 3 hours till the baby survives or till even if maybe the adult life, right? So the patient has to do this. So guys, first thing we have explained. So why there is hypoglycemia? The second very important feature of this patient is that this baby presents with enlarged abdomen. Okay, so how can you explain the enlarged abdomen or hepatomegaly? So as this patient has massively enlarged liver. So why this patient has massively enlarged liver? It's simple. Because, guys, if you have discussed the topic of regulation of glycogen synthesis, have you done that? So, in the regulation of glycogen synthesis, glucose 6 phosphate is the allosteric activator of glycogen synthase, which is a rate limiting enzyme of glycogen synthesis. So, what happens in von Gerke's disease when the glucose 6 phosphatase is absent, deficient? So glucose 6 phosphatase is deficient now. So glucose 6 phosphate levels will rise. Now, as we already discussed, glucose 6 phosphate is activator of glycogen synthase. So obviously the glycogen synthesis in the liver will increase tremendously, right? And it will keep on adding the glycogen to the liver. So we will keep on adding the glycogen to the liver, and this will lead to liver being full of glycogen, and this will leads to hepatomegaly. Understood, guys? So that is our second feature of the glycogen storage disease type 1. Okay, that we can explain easily. Fine. Then, guys, there is one more feature, that why there is increased uric acid levels or hyperuricemia in this patient of von Gerke's disease. Guys, that is again explainable by the same points that we are discussing. Okay, so because glucose 6 phosphate levels are increased, first thing what happened? The first thing that happened is that hepatomegaly happened, that we explained. Second thing is this glucose 6 phosphate will now enter into the HMP shunt pathway. Now, in the HMP shunt pathway, guys, what are the products of HMP shunt? Very important MCQ or question that you must know for viva also. So, what are the two products of HMP shunt pathway? NADPH first, and the second is, can you name me second? Second is the pentose phosphates. Okay. Now, guys, imagine these pentose phosphates. So, these pentose phosphates, they are like ribose 5 phosphate. They will increase, and guys, when they increase the purine nucleotide synthesis. Okay, because in the purine nucleotide synthesis that we will discuss, or in your college, you will be discussing it later on. In the purine nucleotide synthesis, the first step is making of, the nucleotide pentose phosphates. So we have already taking the pentose phosphate from HM patient, and this will increase the purine synthesis. And guys, purines, when they are made excessively without any reason, what will happen? They will be degraded. And once they are degraded, guys, what we get? So we get something that is called as uric acid. So guys, uric acid is the product of purine degradation pathway. Okay, that's why this patient has hyperuricemia. Fine. Now again, few more things I can explain. So these three are must know. Rest for extra points that you can add here. So like let's say why this patient has lactic acidosis. Okay. So guys, because what happens is that because of high level of G6P, the G6P enters the glycolysis, and in the glycolysis pyruvate is formed, right? And this pyruvate has multiple fates, we all know. Four fates of pyruvate that you should always remember. Now, from the glycolysis, we get pyruvate, and from the pyruvate, we have four fates. So, one of the fate is production of acetyl CoA. So, increased amount of pyruvate will leads to increased acetyl CoA formation. And guys, because of this increased acetyl CoA, I will get more fat synthesis. You are done with fat synthesis, I know. Okay. So fat synthesis will increase from the acetyl CoA. Secondly, the acetyl, apart from acetyl CoA, pyruvate also converts into lactate. Okay. And that leads to lactic acidemia, or simply high levels of lactic acid. So now I explain two more things to you. That is why there is dyslipidemia, that is increased level of triglycerides or fats, and second is why there is lactic acidosis. So guys, this is one of the point that is very important, and that is type 1 glycogen storage disease. Clear, guys? So that you must always remember. Fine. Okay, now one more concept based question that can be asked to you is something that is called as glucagon challenge test. So, guys, what is glucagon challenge test? So, in a normal person, if you call that normal person in the morning after 8 to 10 hours of fasting, right? And then you take that patient's blood sample, person's blood sample, that will be any person without any disease. Okay. So when you take the when the person enters into the laboratory hospital, we take the baseline blood sugar level. Suppose it was 90 mg per day. Okay, what is the normal range of blood sugar? 60 to 100 mg per dl in fasting state. So suppose this person has 90 mg per dl. Now, if I give the glucagon injection to this person, what will happen, guys? So, guys, when I give glucagon injection to this person who is not known to have any disease, what will happen? Guys, glucagon, again, the regulation of glycogen metabolism. Glucagon activates glycogenolysis, that is breakdown of glycogen. How does it do it? Glucagon activates one enzyme that is called as glycogen phosphorylase. Okay. And guys, this glycogen phosphorylase is a rate limiting step of the glycogenolysis. Also remember it is B6 dependent. Okay. So when the glycogen breakdown increased because of glucagon induced activity of phosphorylase, the more glucose will be produced from glycogen in the liver, and this will increase the blood sugar level. So suppose after giving the injection of glucagon, same patient has now a blood sugar level of let's say 150 mg per dl. So that's like very high. So that means this is called as positive glucagon challenge test. So when you give glucagon to someone who is appearing healthy, at least not known to have any disease, this will cause increase in the blood sugar levels, right? And that is called as positive glucagon challenge test. But what will happen to this patient, guys? Von Gerke's disease. If you give glucagon, nothing will happen. Why? Because glucose can never be formed in the liver of this patient. Why? Because the last step of glycogenolysis, which converts glucose 6 phosphate to the glucose, is absent or is missing, is deficient. So there will be no positive glucagon challenge test. Hope you understood, guys. Huh? So this is the basis of this point. Fine, guys, that is type 1 glycogen storage disease. Now, one more concept based question in the same topic of glycogen storage disease that I want to explain here is that why in the type 5, that is McArdle's, and type 7, that is called as Taroi's. If Taroi's is not taught to you, that's fine, no problem. But McArdle's must be there in your curriculum, at least taught to you in your medical college. So in McArdle's disease, why there is no, lactic acidemia? Okay, if you ask the patient or if you perform something called as ischemic exercise test on the patient, so why there is no increase in blood lactate levels? Okay, let's understand, guys. See, if I do exercise, okay, under low oxygen concentration, so obviously the lactic acid will increase now. Because what is the product of glycolysis in anaerobic condition? Lactic acid. And guys, muscles have very poor blood supply. So when we perform any exercise under low oxygen tension, okay, this will lead to lactic acidemia. Fine. And normally also if I perform any exercise after a long time, because my blood supply to the muscle is low, it will lead to lactic acidemia and the pain. But in this patient of McArdle's, there will be no lactic acidemia. Why? Okay. So because guys, in the patient of type 5, that is McArdle's, muscle glycogen phosphorylase is missing. So when the person start exercise like running or lifting the dumbbell, what will happen? The glycogen will break to G6P in the muscles. But G6P will not go. Okay, I'm correcting myself again. So in the patient of type 5, the glycogen will not break at all, right? Because glycogen phosphorylase is missing. So obviously no pyruvate and no lactate formation. But guys, in type 7, that is Taroi's disease, you know what happens? There is again no increase in blood lactate levels after exercise. Why? Because glycogen will break to the G6P, but G6P should enter into glycolysis to make the lactate now. But what is the absent enzyme in Taroi's disease, type 7? It is muscle and RBC PFK1. So obviously, guys, the glycolysis cannot happen from the G6P made from muscle glycogen. So obviously, there will be no increase in blood lactate levels. Understood, guys? So that is your one of the very important concept again on the type 5 and type 7. So guys, type 5 and type 7, they have a similar, clinical feature like, exercise intolerance. They can't perform the exercises. So it is similar. But what is the difference between the two? The most common difference is the muscle and RBC PFK1 is missing in Taroi's. So in the Taroi's, Hemolysis is also one of the component that can differentiate type 5 and type 7. Okay. Then guys, let's move to the third point. They can ask you again one more question, that which of the following diseases presents with abnormal structure of glycogen? So what is the name of accumulated substance? Glycogen, but it has abnormal structure. So which two disease has abnormal structure of glycogen? Only two. Type 3, Cories. So guys, in the Cories disease, debranching enzyme is missing. So glycogen cannot be broken completely. So we left with small chains of glycogen still present at the branches, and that's called as the limit dextrin. So type 3 Cory's disease has limit dextrin type of structure. Okay, small chains of glycogen still left on the main structure of glycogen. And type 4 Anderson's disease. So guys, what is happening in Anderson's disease? What's the name of enzyme deficient? Branching enzyme is missing in Anderson's disease. So guys, when the branching enzyme is missing, means what kind of glycogen will accumulate? So glycogen with lesser branches compared to normal. See guys, normally glycogen branches at every 10 to 13 glucose. Yeah, just remember 10. So glycogen branches after every 10 glucose residues. But now it is not branching because branching enzyme is less. It's deficient. So I will get a glycogen which will be either linear, hmm, or it will be something which is having very less branches. And guys, this type of glycogen is compared with starch, which is amylopectin. So amylopectin is a type of starch which has branches but very less. Only one branch after 30 to 35 glucose. But in glycogen, it should be one branch after every 10 glucose. So obviously, we are comparing now type 4 with the amylopectin structure. So we also call type 4 as amylopectinosis and type 3 as limit dextrinosis. So they can ask you like why we also refer type 4 disease as amylopectinosis, or why type 3 as limit dextrinosis. So hope you understood, guys. Huh? So type 3, type 4, we have also covered. And these are the only two diseases which present with the abnormal type of glycogen structure. Rest all have normal type of glycogen structure. Okay. Now, guys, coming to type 2, that is Pompey's disease. So though Pompey's is very easy, and what is the only point we have to remember in Pompey's most importantly is that this is the only GSD, that is glycogen storage disease, which is presenting as LSD, lysosomal storage disease, like Hunter's, Hurler's, Gaucher's, the names that you might be knowing. So Pompey's is the only glycogen storage disease in which the glycogen accumulates inside the lysosomes, not anywhere else, not in the cytoplasm. So that is unique about type 2. Okay. And one or more unique point that we can add in type 2 disease is the presence of cardiomegaly. Okay. Presence of cardiomegaly, right? Because heart enlarges here because of accumulation of glycogen. Normally, heart has very insignificant amount of glycogen. Except muscles and liver, most of the tissues have insignificant glycogen stores, or accumulation is rare, right, in them. But here it is being accumulated inside the lysosomes of liver also, heart also. So hepatomegaly, cardiomegaly, hypotonia, etc. A lot of features are there. Right, guys? So that's all about this point. That is on the glycogen storage disorders. And you must, read them carefully. And there can be a lot of questions in your exams from this topic, including viva and MCQ. Okay, guys. Thank you so much. Keep studying. I'll see you again later. Bye.